this morning. It is an important day for Rhode Islanders that need a primary care doctor. And that will not come as news to members of the press who are here, nor more importantly will it come as news to the Rhode Islanders that are finally dealing with the healthcare crisis that some of us have seen, and frankly, all of us in leadership should have seen coming now for some time. Whether that was the Anchor medical closing earlier in the spring, not because of anything that they didn't do, but because of the structural problems in Rhode Island when it comes to funding healthcare, including primary care, left 25,000 patients effectively in the wind. We know we have a problem. So, how do we get to where we are today, and what does today mean for our primary healthcare crisis? Well, it means this. Brown and President Fernandez and his colleagues can speak, I think, better to this than I can, but Brown has something of a odd organizational structure. You have Brown University Health, and a physicians group at Brown University Health, including primary care, quite a few primary care providers treating quite a few patients. But there is also this entity called Brown Physicians Inc. And I have no doubt that many Rhode Islanders think those two things are the same, but they are not organizationally. What Brown Physicians Inc. is a group of providers that do, among other things, dermatology, emergency medicine, primary care, neurology, urology, and surgery. And they are separate and apart from Brown University Health. And yet they are at Rhode Island Hospital, and other Brown University Health hospitals. And in fact, it's my understanding that some of members of Brown Physicians Inc. Have been or are department chairs of various components of Brown University Health. The bottom line is there's a lot of overlap there. So organizationally, it has been Brown's, both BPI's and Brown University Health's intention to bring those two groups together. Now, I have a responsibility under Rhode Island law to ensure that when entities that do similar business, whether it be in healthcare or anything else, combine, that does not lead to a restraint in trade or commerce or lessen competition in a way that harms Rhode Islanders. So when Brown University Health and BPI brought to our attention that this was a transaction that they were interested in completing, we undertook last year a review of the transaction, looking at it under our antitrust authority, which again looks to determine whether or not this combination would restrain trade or commerce or lessen competition. We have now concluded that review, or at a minimum concluded it to the point where we are prepared to suspend it, provided that Brown and BPI, once coming together, take significant steps to address and alleviate the primary care health crisis facing our state. So what does that look like? We are requiring that Brown University Health take on 40,000 additional new primary care patients over the next 4 years. That is, and as you'll see on some of the slides that are passing through behind me, that is a significant increase over what those two entities are currently seeing combined, and we believe it will be a major step forward in alleviating our primary care crisis. Among the things that Brown is committed to is ensuring that new patients wait only 14 days for a new patient appointment. If you have called around trying to get a new patient appointment over the last several years, you know that to get an appointment within 14 days, well, if you've been able to accomplish that, you should go play the Powerball, because your odds are probably better winning the Powerball than finding a new patient appointment anywhere in the state within 14 days. Brown has committed, Brown University Health is committed after this combination that they will hire physicians and advanced practitioners, nurse practitioners and others at a 1-to-1 ratio minimum. What that means is there are some in this state that believe that primary care should be delivered only through advanced care practitioners, advanced practitioners in primary care. I disagree. I think there is a role, and many others think there is a role for primary care physicians, pediatricians, internists, family doctors, and others, but people with a medical degree to practice in this state as they do in other states and be part of a healthcare team, a primary healthcare team that can adequately, and more than that, best treat Rhode Island patients. Brown expects that they'll need 27 primary care practitioners to hit this goal of 40,000 new patients over the next 4 years. That is going to require robust recruitment and retention. You can't get 27 new ones in the door, in the front door, and lose 27 out the back door. So this is a net increase of 27. So that's sort of their goal. We've set some interim marks for them to hit along the way rather than rely on actual patient counts in the first couple of years. Why? Because the way recruitment works in the medical world, as in law, at least in big law, is that recruitment period is either just behind us for next year or ongoing right now. And Brown's going to have to work really hard next year to hit those interim targets. But we wanted to give them a little bit of space to ramp this up and get it going. These increases can't be on the backs of existing primary care providers. I'm sure there are primary care providers out there that work for Brown right now that are working really hard and are wondering whether or not they're going to have to take on these 40,000 new patients. And we insisted, and Brown agreed, that that would not be the case. Without getting into a lot of details as to how they pay their physicians, the bottom line is that their physicians will continue to have choice as to how many patients they see on their panels. So these are going to be new practitioners that see these 40,000 patients. Now, I don't mean to suggest by that the 27 new people will see the 40,000 new patients. There will obviously be a blend across Brown Health, but those are the targets that we're trying to hit. Brown is committed to providing the support necessary for these new practitioners and existing ones, and to work to truly making compensation competitive with our neighboring states. Why? Because you're not going to be able to recruit these practitioners unless your pay is competitive. That is what it is in a nutshell. Over the weekend, I met a pediatrician who was practicing in either Seekonk or Swansea with support from Boston Children's Hospital. And she told me, she lives in Barrington, and she told me that she works 3 days a week while her friends that are pediatricians in Rhode Island work 5 days a week to make it essentially the same thing. That is the truth. That is the reality. And we could ignore it if we want. But the bottom line is, if we want to build a great primary care system and become a magnet for primary care doctors, it's about the economics. We've known that for a long time, and we just have to acknowledge that truth. And then the last thing I want to share is that we're going to be we are requiring, as you'll see from the agreement, in-depth reporting from Brown twice a year regarding how many patients they're seeing, how long it takes for a well visit, how long it takes for a sick visit. We want to know how it's going. And so if we have to push, then we will. That is what I think this office does rather well, frankly. But it also will give us that data from one of our largest healthcare system, and certainly our largest primary care provider, I believe at that point as well, is real insight into the overall state of play in the primary care market. One thing that we have talked about a lot here is a lack of data to help drive policy-making decisions, and we hope that the monitoring that we're imposing here will help us in that effort. And so those are the basics of what we're announcing today. I'm going to turn it over to John Fernandez, President of Brown University Health. If there are questions, then I'd be happy to take them after everyone's made their remarks. So thank you. John?
Thank you.
Thank you, Mr. Attorney General, also known as Peter. I want to start by just thanking the AG and in particular his staff that's here and back there. A lot of people worked really, really hard to get this transaction done over the last year. So a big thank you to all of them. And second, this agreement to bring the two organizations together is really important to our long-term strategy, to be one Brown Health, to bring our academics, our research, and remember, we're teaching the next generation, we're doing the research to find new treatments and cures, but most importantly, caring for people here in Rhode Island and in the region. So it's a really important part of our strategy. Lastly, I'd like to thank my team at Brown University Health, whether it's our lawyers, our finance people, our PR people, all the people that had to work on this, but in particular, our physician leadership, our department chairs, and that leads directly into the next two people that are going to speak, which are Angie Caliando, Dr. Angie Caliando, who's the president of Brown Physician Inc., and Barbara Kokar, who is our chief physician officer and is president of Brown Health Medical Group, and they're going to give a few remarks. So, Angie, why don't you come first?
Thanks, John. Good morning, everybody. So I would like to take a minute to thank my Brown Health Medical Group colleagues and my BPI colleagues. I will say this was a lot of work, a lot of hard work went into this, and I think it's a very important accomplishment. And I'm really delighted that we're here. It's been a long time coming, and it just feels great to finally be at this spot. You know, BPI physicians have long worked closely with Brown Health. It's where we admit our patients into their hospitals. We work side by side with our Brown Health Medical Group colleagues caring for patients on a daily basis. So it was only natural that the next step in this process would be that we would come together in a formal merger. Now, I think one of the big benefits of this merger and coming together is that we'll finally be able to be on a common electronic medical record. And this really allows us to share information much more easily. It allows us to coordinate care more easily, share information between ourselves. And I think this has been something that we've needed for a long time. And I think it will also help us be more efficient at what we do. And it will help patients, because instead of being in multiple patient portals, seeing one physician that didn't know what was done at another physician's office, a lot of that should be improved by these two groups coming together and being on a common medical record. So I think there's value for both the physicians and the providers as well as for patients. As the Attorney General pointed out, I think this is also going to help with access, particularly around primary care. So really, the merger is all about driving better patient experiences and better patient outcomes. And so I personally am very excited. I think my colleagues in BPI are very excited to move forward with this and to move on to the next adventure. So I am going to turn it over to Barbara Kokar. As John said, he's the president of Brown Health Medical Group and the chief physician officer for Brown Health. Barbara.
Thank you. Well, good morning, everyone. First of all, I'd like to thank the Attorney General and his staff for all the work they've done with us on this important agreement, as well as our leaders at Brown Health and BPI for their support. So today is a real transformative moment that's going to elevate the care we provide across Rhode Island. With this merger, we can formalize our long-standing partnership with BPI, making collaborative care even more seamless. Bringing our two groups together reinforces our commitment to community-based, patient-centered, and innovative care. Most importantly, it aligns with our ongoing efforts to invest in and expand primary care. By combining our specialty and primary care teams, we are equipped to deliver coordinated, comprehensive care to more patients in Rhode Island and the region. Today's merger of Brown Health Medical Group and Brown Physicians Incorporated will allow Brown University Health to continue to be a leader in research, education, and patient care. I'm going to turn it back to the Attorney General. Thank you.
Thanks, Doctor. Doctors, I should say. Okay, if there are any questions? Yes.
The FTC also had to review this proposal. Where do they stand? Have they explained to your office where they stand?
The FTC is adamant about this office not commenting on what they do, and so you'll have to reach out to them, Alex. I believe that they may be taking something up within the next couple days or so, but I can't speak for them.
So they have made a decision though?
Well, they make decisions by a vote of the commission, so their staff, and staff makes a recommendation to the commission. So until the commission votes or acts on that recommendation, they really haven't made a decision. So I think we'll just let that process play itself out. But we have a very strong working relationship with them.
Do you know what the staff recommendation was?
Did that answer your question?
That helps, thank you.
You're welcome. I know what it is, yes, but I don't feel like I am in a position to share it.
Two questions.
But I expect this transaction to move forward, let's put it that
Two
way.
questions. General, first, we're already hearing from people who, with all due respect to John, are very worried about how big Brown Health is getting. And I know that's part of why there was an antitrust review here. Can
Sure.
you speak directly to that question of, it's what we were here talking about 3 years ago with the Lifespan merger?
Sure.
How the state keeps reins on what is becoming almost a public utility in healthcare?
Yeah, look, I don't think, if you look at those numbers that just flashed up there, when it comes to primary care, so we're looking at, various segments of the market and how much in each particular segment of the market, Brown has a concentration. So certainly 200 and some odd patients is a lot, but that's good. We need primary care growth. It's also 20% of the state's population. So they're not seeing 100% of the state's population. So that would be my answer to the people you're referencing. Now, I don't know who you're referencing. If you're referencing insurance companies?
No, I'm referencing general public. I get emails like
Yeah,
this.
well, general public, yeah, so that's my
General
answer.
public sees Brown Health on that, they see a Brown symbol on the doctors, and they just feel there's a great deal of power in that organization. It's not necessarily cast aspersion, it's just people want.
No, so let me clarify what I'm saying. I think if you're asking everyday Rhode Islanders what they care about, they want a doctor's appointment. I don't think they're worried about Brown being too big or with the color of their logo. They want to be able to see a doctor within 14 days or 30 days, or not 6 months and not be able to see him at all. The reason I reference who those people are, because I get that question a lot. What do you say to the people that say? And so if this gives Brown some more power in the marketplace, then I don't necessarily see that as a bad thing. I think the marketplace in some ways is tipped too heavily in favor of insurers, frankly. And I think that has been with the assistance of the Office of the Health Insurance Commissioner. When you raise rates on Rhode Islanders on almost 20% of the population by 50% over 5 years, who's winning? Insurers. I think government needs to do more. Medicaid rates need to continue to go up. Now, we made progress on that in the last session, and I give the Speaker and the late Senate President and the current Senate President great credit for, frankly, listening to us and raising Medicaid rates to Medicare rates. But we still have more to do, and not just for primary care. So if I was truly worried about Brown being too big and restraining trade, or making it harder for Rhode Islanders to get a primary care appointment through this combination, I would not have permitted it to go forward under these conditions. But that's not how I feel, and that's not how the team feels, and so I'm confident this will be a vast step forward when it comes to getting Rhode Islanders, everyday Rhode Islanders, a primary care appointment, which today they just can't find.
And John, just before I'll let someone else in, but can you just say the TikTok of like what day BPI is part of Brown Health? Like how does what happens from here?
The TikTok, I never thought I'd be commenting on TikTok. My kids are gonna be really proud. Thank you for
I think
believing.
I think he needs a clock, I think, but maybe he does need
I
TikTok.
think he's really modern. He's into the TikTok
I
thing.
didn't ask you at OnlyFans.
So the actual merger will occur on October 1st. We will begin that. But I gotta tell you, there's a lot of work from that official date all throughout next year to implement, like the longitudinal medical record won't happen till the end of next March. But the process for us will begin immediately, because the first, as I last looked, is tomorrow. But that process will take us over a year to implement all the pieces, and as the Attorney General mentioned, we still have a lot of people to recruit and a day job to do to care for lots of people. So it gets started quickly, but it may sound quick, but the actual implementation takes a long time.
John, while you're up there, what is the estimated cost to Brown University Health of both the actual merger and then this additional hiring? And with that follow-up, how is that going to affect investments in your two new Massachusetts hospitals?
I'll work backwards. It will not affect our investments in Massachusetts. The cost to us, at a barest minimum, in the electronic medical records, I think about $20 million in capital, and then we'll be financially responsible for Brown Health, all Brown Health, and so whatever that brings. But we don't know all that yet. But we know it will cost.
What about the cost to hire 27 new primary care practitioners?
Barbara, you got a guess?
Over the 4 years, we're estimating around,
How
Let me
much?
four.
How much?
About 4 million over
4
there.
million.
Is
And
that on the run rate side, 4 million? Just 4 million in terms of,
Once we're
revenue?
fully staffed, yeah, because it's not just the primary care provider, it's the staff, there's space, all this.
4 million per year revenue. Well, how does that affect your margin? I know Brown University Health has been working on a very, very slim margin. I mean, net, is this gonna put you below the line?
We sure hope not. Our plan is to make a 3% margin. We're making a lot of progress there. This should actually help us because access to primary care, if you don't get access to primary care, don't use the specialists, don't use the hospital, they go to other states. That's what happens. And so having great primary care is really important to us as an organization, our long-term success.
And with that, you're gonna need to find doctors. Is the compensation structure such that you're going to be offering more to new hires than what you have previously, noting the competition and pay issues?
You want to answer that?
Yeah, no, so we sure. So we actually went through that process last year. So we have a new competitive compensation model that our clinicians created, so they're quite happy with it. So we believe it's competitive with them.
But is that the same compensation model you've been using in Massachusetts where you haven't been able to hire enough staff after people left?
Well, Massachusetts is a whole nother issue, and what we're doing there is very different than in
But
Rhode
it's
Island.
not the same compensation model, or it is?
Well, we don't have primary care providers ourselves in Massachusetts.
Also, the conditions, this is more for John and the Attorney General, but, it says to at least hire 27 new PCPs. And obviously, John, that's your mandate, is to make sure that you hire those, but Attorney General, was there any conversation about making sure that those 27 or at least 27 PCPs come from outside of Rhode Island? Otherwise, we're just kind of moving PCPs back and forth between one institution to the next in Rhode Island.
There has to be a net increase in Brown of 27 doctors. So your question is a good one, whether that would come from potentially other systems. It's possible, it's possible. My hope, though, is that when doctors are leaving residency, new doctors, which is where I think much of this recruitment will take place. I mean, Dr. Kokar can speak to this. And that's one of the reasons why when you're recruiting people on a residency, those applications have already gone in or they're going in now. My hope is that Rhode Island will become a place where doctors want to come to practice. Certainly there will be an exodus from primary care elsewhere in the state that we have to work on. That's why the overall structure of how we do primary care has to continue to change. But I felt like this was an opportunity to use our antitrust authority to ensure that at least one major institution over whom I had jurisdiction in the moment committed itself, regardless of what the cost is, to bring on the number of patients, that will be a major step forward. And look, there was a lot of negotiation back and forth over how many patients they would agree to take on. I obviously wanted more. They wanted to do less because they wanted to make sure they could do it. And so we really wanted to make sure that these targets were as great as they could be, but within the realm of being able to do it. But I'm confident that they'll be able to do it. And if they don't, well, then, there are consequences for that.
Medicare Advantage. So for the patients that are under Medicare Advantage, under United, what does this mean for them?
Well, someone else is gonna have to answer that, because I have no idea what it means for people who are on United's Medicare Advantage.
If you're Medicare Advantage with United, right now, we don't have a contract with them. So hopefully they'll move to either Medicare or another program, if they want to stay on Medicare Advantage and still be our patient. We couldn't work out an agreement with Medicare Advantage.
General, hi, you've got a hearing this afternoon over in federal court on the Novartis case.
Yeah.
The 340B, chapter 288. What's at stake here financially, should the judge issue a temporary injunction?
Well, look, I'm not gonna get into sort of what the downside risk is, because I don't expect we're gonna face a downside risk. I think we're gonna win that case. And I think it was well within the General Assembly's authority to do what they did, and we're gonna defend that today in court.
Let's say you lose, how much money is it?
I'm not worried about losing. I never worry about losing. I only think about winning.
In April, Governor
Because that's most of the time we win. And if we lose, then I'll figure it out. Yes.
In April, Governor McKee announced in his words, long-term strategic plan to strengthen the primary healthcare system here. How does this now impact that?
You wanna remind me what that was?
He had a whole long-term strategic plan that he had put out there. In April, we had talked.
Yeah, frankly, I don't remember what it is, because I don't find it particularly memorable. I think he was gonna have the health insurance commissioner do a study for 2 years. We can't wait 2 years to get action on primary care. We've got to start this process now. We're already behind. Rhode Islanders can't find a primary care physician. So, look, I think in this, let's be candid. There's an election next year. As issues become hot button issues that have been neglected, the conversation comes back to, look at what I've done. Look at what I'm doing. Let's take credit for things I haven't done. That's all that, and that will take care of itself, and Rhode Islanders are smart enough to understand what all that means. What we're talking about today is, we have authority here. We're a regulator. We see a problem. We're gonna try to fix it. We're gonna negotiate with Brown to try to advance the ball. I think today advances the ball. Does it solve the problem statewide? No, because we're not a mecca for primary care. We can and should be. And it doesn't always necessarily require more money. Sometimes it's taking the money we're spending and allocating it differently with respect to my specialists over to friends to my right. Sometimes it's valuing the people who are the air traffic controllers of our healthcare as much as we value our neurologists, as much as I love neurologists, doctor. I've said this to Blue Cross executives as well. Be bold. Take the pool, take the pie, just spread it around a little differently. You don't necessarily have to raise the dollars. Just reallocate them.
Just with that, 20 million in capital, 4 million, is it 4 million per year, 4 million over 4 years for the hiring of 27 new?
Well, once we're fully hired.
So 4 million in total over 4 years.
It's a $4 million add to the budget once everyone's up and hired.
Are you worried that investment in primary care is going to revive cuts to the Newport Birthing Center or to, psychiatric beds at Rhode Island Hospital, all these other things that President Fernandez has already laid out as being on the line for cuts, critical services?
Sure, I don't want to speak for them, but I'm worried about the amount of revenue coming into our healthcare system. Medicaid, Medicare, commercial, all lower than our neighboring states. Until we fix that dynamic, these problems are going to come back. There are a lot of dynamics that go into deciding what lines of service. That's why there are regulators as well, to make sure that before lines of service are altered, that those lines of services, those prospective lines of service changes get the appropriate governmental scrutiny. But I don't think that you can ever underinvest in primary care. And Rhode Islanders know this. They know it because they can't find them. They can't find them. And the problem with the primary care crisis, at least it, getting to the point where people are actually talking about it, is it occurs one at a time. So until you put 100 Rhode Islanders in a room and ask them how many have a primary care doctor, or how many have lost one in the last 6 months, or how many have one that is going to concierge medicine, and you ask somebody to raise their hand if they can't find one, or they lost one, or one went to concierge medicine, or one moved out of state, and then all the hands start to go up, well, then everybody realizes, well, hey, it's not just me that can't find a doctor. And you shouldn't have to go, sometimes we get tagged as a know a guy state or gal state. You shouldn't have to know a guy or a woman to be able to get a primary care appointment. You should be able just to go to your Blue Cross provider network, and seriously run the number and call the office and get an appointment. Notwithstanding what Blue Cross tells you sometimes, that doesn't always happen, as we've seen. So we got a long way to go.
Why
Can I ask a question of the doctors? Because I know we're gonna get, as soon as people see this headline on our website or watch 6 o'clock news, oh great, I need a PCP and there are 40,000 new patients tomorrow being taken. I realize that's not how it's gonna work. I mean, can you set expectations? Who should people call? What is your wait list currently, frankly? Because you guys, as far as I don't know who you guys is at the moment, but I believe Brown Physicians has a big PCP wait list now.
Yeah, so you're right. This is not tomorrow, all of a sudden we have access for 40,000 patients. This is why it's over 4 years. And hopefully at the end of those years is where we'll be able to hit the 40. There's recruitment. We're already recruiting providers now. Because of this agreement, we're gonna start even focusing on this more. As the Attorney General mentioned, this is the time when you start the recruitment process. So we're sort of right in the middle of it. So we'll have to see how we do in year 1 and then see how we do year 2. But this is why it's a 4 year. So yes, it's not tomorrow you're gonna call and all of a sudden we'll be able to get your primary care provider.
So
That's-
what should people do if they don't have one today? Just call and get on the wait list?
I mean, whatever we can do, we're gonna try to do it as fast as we can, but there's nothing we can do right now to solve that.
While you're out there, can you talk to what really has changed in the primary care sphere since April?
Can you be more specific?
Yeah,
It's constantly changing.
That's okay. We got this, we had a press conference when Governor McKee announced that plan. And in his words, it was a long-term strategic plan. But can you talk to what your office has really experienced since maybe that announcement? Have there been any big changes since then?
No, I'm not sure the sort of the details of that plan or what was sort of discussed. Really related to this is trying to address the primary care crisis that's happening in Rhode Island, and as we come together as a group, whether we can coordinate that care on the primary care side, but also on the specialty side.
So you're still getting, inundated with calls, people trying to find their primary care physician and trying to make new appointments?
Do you guys have a number on the wait list?
On our wait list?
Yeah, like how many people are waiting right now? How long's the wait?
Not sure. It was when the anchor changes happened, it was about 10,000, but I can find out what the exact number is.
Has it gone up or down?
Down. Oh, way down. Our goal is to get through the entire wait list by the end of this calendar.
Why did BPI have to get absorbed by Brown University Health? Were there financial ramifications if it wasn't?
No, so just to clarify, BPI, those 6 departments, and Angie, welcome your thoughts here. Those are our departments in Brown University Health. So those chairs and chiefs manage our patient care at Rhode Island Hospital, at the Miriam, at Newport. So those are our chairs and chiefs. They support us. They do our training program. So it really is an interesting integrated system, and this is just bringing the groups together formally the way they should. I don't know if you want to.
I will say that the way that the academic medical center is designed here is unlike any in the country. So when we were going through and doing our research for the FTC, we are the only academic medical center that I'm aware of in the United States that didn't have an integrated faculty practice plan. So there are many reasons to do this, and because it just doesn't work. I mean, you're talking about cost, you're talking about access to care. The more fragmented we are, the more difficult all of that is to accomplish. So I think coming together just allows us to work as efficiently as we possibly can. We're just not structured. We were not structured for success.
Why didn't you merge previously?
Why didn't we merge previously?
Like as part of the Brown lifespan big rigmarole, for example?
Well, we're a different company, and we had to go through our own rigmarole, and we had to go through the FTC to get to where we are today.
Right, but you could have done that years ago.
BPI has only been around for about 8 years, so we came together ourselves. I think if BPI hadn't come together as a group, we wouldn't be here today as easily as we are, because that was really the first step along this path. So it looks like it would be simple to do, but what I've learned over the last couple of years is this is a great deal of work to get to where we are now.
And John, just as a follow-up to that, can you speak to how the merger between Lifespan and Brown Health has perhaps boosted the balance sheet at least a little bit to be able to accommodate these or absorb these extra costs? If that's a factor.
The balance sheet, I'd have to get you the numbers, but it goes up a little because there are assets that transfer, but there's a lot of cost that goes with it, the medical record, but I can tell you, it outweighed, that all is frankly non-important to me, because having a disorganized health system costs money we don't see. We have leases, we have agreements with our doctors. They can't talk to each other because you can't share information. And I can tell you, we asked our outside consultants, several of them, literally no other health system is organized. I got here and I said, on my list, change the name, and this has to change, because you can't compete in a marketplace, and there is competition in Rhode Island, Massachusetts, in New England. People are coming after our doctors from out of state every day, twice on Sundays. So if we want to compete, we can't have a disorganized system. And this is one big step in getting us into an organized health system.
What's the next step, John? What other acquisitions do you have
Top
planned over the
secret.
next 36
Top
months?
secret.
Do you have any other plans to
Yes.
expand further? What are they?
They're not ready for prime time, but we have to keep working. We got to do a better job of seeing the patients we have. That's what this is about. But we have to continue to grow and find revenue streams, improve reimbursement. Not top of my list, as you all, especially press people, witnessed last year. We did a lot better last year with some increases from the General Assembly and the governor. So to your question, what has changed? We got a little more money. It's not close to what was needed and what we put on paper and we're very clear about. And until you fix that money problem, you can talk about the programs, you can talk about, but you gotta fix that. You can't win when you're 25% less than the states adjacent to you and around the country. And we want a thriving healthcare system in the state, not just one that gets by. And that's what we're working on. And this is one of many steps to get there.
General, I have a question on the bridge.
You can take that one.
I will take it, but
No,
I want to
take
make,
it.
well, the bridge?
Yeah.
I don't want the bridge, no.
No, I'm saying, you wait now, you're waiting, and I'll get you after on it?
Of course.
What about
but-
topics of healthcare?
Say again?
Can you provide an update on Centurion Foundation and their acquisition of Prospect?
Yeah,
Holdings?
I can. I just want to make sure we've covered this.
I got one question
Yep.
for John. Earlier you said you were trying to operate on a 3% margin or so, and earlier this year, there was consideration of closing the Samuel Sinclair Dental Center, Gateway Healthcare. With all these investments, and I think Nancy asked a similar question to this earlier, I don't know if it was addressed, does this impact any decisions that you're making on services that you would cut back on?
Nope. We've kept the ones we said we kept, we're gonna keep, but I will say it again, and I've said it to the press, I've said it to the public, I've said it to our board. If we continue to have these economic problems, we will be forced into tough decisions about which programs we have. Whether they're the ones we've referenced previously or other ones, but less money means you can't do as much. The big beautiful bill, not helpful. All the stuff going on, NIH cuts, not helpful. So the pressure is not off, but we have to make these investments like in primary care, like in many of the programs we do, and we're proud of the people we take care of. But we gotta get more people off of Medicaid, get them into commercial pay, we gotta fix our reimbursement system. Until then, we're gonna keep hearing about whether it's us or the other hospitals or health system or doctor groups. And you're starting to get on one. Look, we have hospitals going bankrupt, physician groups going bankrupt. We have a crisis. This is just an important step for us in our success, but we got a bigger crisis we should be more worried about.
I just have one on this specific topic follow-up question for the Attorney General.
Yeah, sure.
I know you said you suspended your review. Had Brown Health, BPI not agreed to these terms, would you have rejected the merger?
Perhaps. I mean, one of the things that we were concerned about, to the point that Ted made, is that if, Brown's getting something here, right? They're putting together a more efficient organization that presumably will make them stronger. Well, healthcare, although it's not a perfect marketplace, is frankly, there's an intersection of competing entities, government, insurers, providers, and more. And so as somebody becomes stronger, that can have an impact on the marketplace. And so we wanted to make sure that in exchange for approval, that they took steps to address how that additional leverage could be used, in that, you've got to see more patients. Well, they're more important to your network, insurance network, than ever. So we understand that gives them more power. The question is, where does that power fit in the marketplace of power? And understanding that, who has what part of the pie, helps make these decisions. But the primary care crisis is so acute that to not use our authority to try to advance it and just let it happen without taking any action at all would not have been responsible on our part. I felt it was an opportunity to move forward. Look, if I controlled all the levers of government, could we do more? I think we could. We're doing everything we can within this office's power to help the primary care crisis. I am all over the insurers for not having an adequate primary care network. They sell you insurance, they tell you there are doctors, there better be doctors. That hasn't always been the case. I have been all over the General Assembly and the governor for not raising Medicaid rates. They finally did it. There's more to do. Look, does anyone out there know how much Massachusetts is spending for Brown to take these two hospitals? Does anybody out there know that answer?
I think it was $700 million for everybody who got a Stewart House.
$70 million over 10 years. How much public money has gone into a hospital in Rhode Island? And I'm not, don't tell me about rates going up and this and that. Tell me how much direct public money has gone into a hospital in Rhode Island. And I'll tell you the answer is zero. The only money, public money, that's going into hospitals is the $52 million that this office recovered from Prospect that's going to go to Fatima and Roger Williams, which will get me to your question in a minute. That's it. So when I sit around with other state leaders and they tell me there's no public money, what I say to them is, well, there is in Massachusetts, and at some point, this state may reach the point where public money is going to be required to support our hospitals. It's either that, or there's going to be closures, or there's going to be no birthing center at Newport Hospital, or no psych unit at Fatima Hospital. That's where we're headed, folks. When really strong private practices are circling the drain, it says something about our healthcare economics. And I've been talking about this for 3 years, to the point where I need my Northwestern Health medicine and water bottle to keep me going, because my throat is getting dry from all this talking, which probably brings you some relief.
What are the consequences?
All right, so I want to go.
What are the consequences if Brown doesn't hit the numbers for hiring new primary care doctors? And
They're going to have to
reaching
give
the
us a
number of patients?
good explanation why. Because we have suspended our antitrust investigation based on that commitment. So we have given them more marketplace power. In exchange for that marketplace power, I want progress on primary care. And there's one place to get it. We're not getting it from government. There's one place to get it, and it's to get it from them. So that's where we're going to get it. That's the goal.
What kind of actions could you take to actually enforce that these numbers are?
Start our investigation again. Sue to undo the merger. They're all in the playbook. If we need to use them, we'll use them. That's why they've got to do it. We didn't sit down over coffee and work this out, did we, John?
I wish we had, but we didn't.
It took a long time. And I appreciate Brown. Stepping up the way they did, because it was pretty intense. Anyway, before I forget, I want to introduce my amazingly good staff, which, again, because you see them a lot. Jordan Broadbent, who does mostly insurance, but not all. Steve Pravazza, who is our antitrust guru. He did the, what did you call it? The rigmarole? The rigmarole of Lifespan and Care New England, among other things. And then Lee Staley, a veteran of the Trump administration like me. We have our scars, Lee, but Lee's our healthcare team now and does an excellent job. We work for federal HHS and is a really brilliant healthcare practitioner, and then ably led in the back by Dee Goldstein and Kate Sabatini and Sarah Rice, all fine attorneys. All right, Alexa, and then we'll get to the bridge, Ted. Yes.
An
Oh,
update
yeah, an
on
update.
what's going
Yeah,
on.
look, you know, the hospitals have come to us and asked us to tweak the deal so that they can have less cash on hand at the time they commence operations in an effort to raise the money they need to close this transaction. And so.
Wait, different from the last time we were in here?
Correct.
So there's a new request?
Correct.
What was this request?
Within the last couple of weeks.
Will they ever be able to
Well, that's
get it together?
Well, I hope so. You know,
What are the changes?
it's just, I think it's about $9 million less cash on hand when they start.
9 million less than the already revised
Correct.
agreement.
Where does
Did you
it
say
stand?
okay to that?
I'm sorry?
You said okay to that?
I did. Because the consequences are to spend $30 million in the Dallas courtroom in bankruptcy court, and that would probably come out of the $50 million I'm holding, and I don't want to blow it on that. I'd rather give them a chance with less money and see what happens in Rhode Island. And see if they can turn it around. And if they can't turn it around, well, then we're with a receiver in Rhode Island, which is better than being with a bankruptcy court in Dallas, as good as the judge has been to us down there.
Did you add additional conditions in agreeing to lessen the cash on hand?
Yeah, stop interrupting my vacations. That goes for you too, actually.
When is their new deadline? Do they have it?
You know, they don't have phones on Mackinac Island either. I'm sorry, go ahead, Alexa.
When is their new deadline? Do they have a new deadline?
They don't have a new deadline, but I suspect if it doesn't close by the end of October, that'll be the death knell for this transaction. So, to make it clear, my answer to them was, you're not getting any money out of the state. That's not gonna happen, let's be realistic.
Did they ask for that?
They did, and they're not getting it, which doesn't surprise me. And so I told them, you know, I'll give you relief from that $9 million that you say you need, and, you know, see if you can close it, and then we'll see how you do.
And when you say they asked for it, was it a joint ask between Prospect and Centurion, or was it Centurion?
Centurion.
Okay.
Yeah.
Did it come up in all of your negotiations with John that if
No.
this deal falls through, you want them to buy these
No.
hospitals?
No.
John, would you like to reiterate that you don't want those two hospitals too, or would you consider actually taking
Never
them
say
on?
never.
Never say never, but
In politics or healthcare.
She was asking John.
I know. Well, I kind of like him to buy them.
Yeah, clearly.
I'm joking.
John, I still have that question for you, sorry.
so we are not interested. We're in bad financial shape. It won't help us financially, but the problem is if they close or go bankrupt, all those patients end up at our hospitals. And we
John,
see-
could you just come to the podium with the general
Yep.
and just say, you know, if this, we've been talking about this so long, I think people get it. What would happen if even one of those hospitals had to close, the spillover effects on the rest of the hospital, Rhode Island's hospital, network of hospitals?
So the scenario would look like they have 50,000-ish emergency department visits a year. Those end up at most likely Miriam Hospital and Rhode Island Hospital, so that's 50,000 more. We don't need 50,000 more visits. That would be fine if, we need them to stay open. That's a sort of tsunami of patients, and I wasn't here, but all you have to do is look at the memorial closing, and you'll see that over again. It's crushed. We now are renovating the emergency department at Miriam Hospital so it can handle more patients, but it went from a hospital is doing 20, 40,000, now there's 80,000+ visits a year. So this would not be a good thing, but it's also not, from a fiduciary point of view, to purchase two bankrupt hospitals with a whole bunch of other things that go with this. Not to mention, there's a bunch of regulatory things, you know, we're not supposed to be expanding hospitals here in the state. according to my friend back here. But. so-
Without a plan.
Yeah, without a plan. So we are not pursuing it, not interested. We've been trying to be as helpful as we can with the folks at Centurion and Jeff over at the two hospitals. So, but that's the extent of it.
So if you want to understand, why do I keep bidding against myself in the Centurion transaction? Well, that's why, because the alternative is worse than doing that. And my hope is that, so what happens if they can't close the deal? It goes back to bankruptcy court. Could there be another sale process? Sure. Are people likely to bid? I don't know. And Prospect, wants to close these hospitals. They'd love to close them right now. And that's what I'm trying to avoid. For that reason, as John articulated, but there are 80 to 90 behavioral health beds. Is it Fatima that they're at, or is it Roger Williams? I can't remember. Both. So as you put those two together, Butler can't take those. Like you talk to Dr. Wagner at Care New England, he can't take those patients. So on Centurion, we're really between a rock and a hard place, but it goes back to the fundamentals of why can't those hospitals succeed? It's because they have a 40% Medicaid patient population or more, and Medicaid, Medicare, and commercial rates are all lower here than they are in Massachusetts and Connecticut. And when you put those two things together, hospitals can't succeed. I mean, reimbursement rates for primary care are so bad now, so low, that it is almost, how practices are succeeding independent of a large healthcare organization, I don't know. When my wife first came to Rhode Island with me, I dragged her here, not literally, 30 years ago, she practiced with 2 other doctors, and they had their own practice, and she did fine economically. And then, she joined Coastal because she had to join Coastal. Coastal was big; it was like 100 some providers, and then Coastal wasn't big enough to survive. And now, hospitals lose money on primary care doctors. They don't make money on them. As much as we've tried to raise reimbursement rates, they're still losing money on primary care doctors. And that's not the fault of the organization. That's because it's really hard to make money in primary care. It's just the reimbursements have not kept up, and that's a structural problem. It's broader than just primary care. It's broader than that. But I feel like we've talked about this so much that I think we're all tired of me talking about it.
Well, then I'll ask you about the bridge.
Anybody else on healthcare? Mercifully, no. All right, go ahead. Yeah, I can't believe I'm looking forward to talking about the bridge.
So, the TikTok of the last couple of days on all this, the governor's comments to all of us yesterday when asked about the audit were generally about the litigation and the lawyers. Lawyers told me I couldn't release it, etc. And if you want to know why it's out, you have to ask the Attorney General why he posted it. The frostiness between the two of you. Why?
That's got nothing to do with why it was posted.
Well, exactly. Why did you post it?
I posted it, as I said several times now, because there is a Instagram account called What's Up Rhode Island that has, over the course of days, weeks, months, been dribbling this thing out, and it had gotten to the point where it can be manipulated when that happens. I don't know who's behind What's Up Rhode Island. I have my thoughts, but I'll keep those close as a close hold for now. And then I'm told that media outlets were getting copies of it, and I got a request from your outlet as to whether what you had in your hand was authentic. And the best way to handle that is just for you to see the real article, and then you can decide whether it's authentic or not, and I don't have to go through your copy. That's not ideal. This case is going to be a battle of experts, and this is one expert. There are going to be many more from a lot of different companies that in a courtroom someday will be giving their various opinions, and a jury or judge, if it's a jury waived trial, will have to divide the blame pie. It's not a shock to me as a Rhode Islander that a state agency may carry some blame here. That was true when I was U.S. Attorney and the Carty constructed bridge railing on the I-95 bridge failed. But the litigation is about taking the blame pie and dividing it up And even if the state eats a piece of blame pie, the other parties may eat some pie too. And that's what that case is going to be about. So this report is one report. It is what it is. I posted it, not because of any frostiness between the governor and I, but because of what I just explained, and I felt it was better for the real article to be out there rather than some unknown outlet dribbling it out in dribs and drabs and creating chaos around it. So that was the reason for it. So why not do it in the first place? Why was the illegal advice, both from the governor's initially retained counsel, Max Wistow and others, as the governor, has stated, why was the advice to him, and is our advice to all of the state agencies and all of the clients that I've ever represented in private practice, admittedly in Massachusetts, is you don't try your case in the press. You just don't do it. We're not going to put 30,000 pages of discovery up on a website for uninvolved experts to opine on, so that when it's time to pick that jury, we can't find anybody who can sit on it. There's too much at stake here. Look, we all know that the bridge failed. Nothing about not releasing the report, in my view, and I've said this before, prevents the General Assembly, if they wanted to do oversight, they could have done that, and they could have made Peter Alviti answer questions a year ago, just like they could have made the governor answer questions about ILO a year ago. So frankly, I'm a little skeptical when the General Assembly all of a sudden wants to be the enforcer, okay? There's one enforcer in Rhode Island, in my view, and you're in that office, if we're being honest with ourselves. So I'm not all that interested in their oversight. I can't remember the last time they put anybody under oath, and if you don't put anybody under oath, you might as well just wave the white flag. That's why grand juries exist, because you put people under oath and you squeeze the truth out of them. So you want to put people under oath? Go for it. But you could have done it a year ago, and you didn't need this report to do it. So spare me the outrage, frankly.
Why though? The lawyers, as part of discovery, you have to give the other lawyers the
Sure.
So,
And vice versa.
And vice versa. So it seems like the only people who weren't allowed to see what the governor's expert had come up with about blame was the public.
Right, because there's a trial, and that's the way trials work, Ted. And if you want to change the way the court rules work, the Superior Court presiding justice is down the hall. What I'm waiting for is the phone call from the trial justice who asked me why I posted it, because it's not entirely out of question that judge may take issue with that. But I did what I thought was best under the circumstances. I have an obligation to the state and the people of the state to handle this case within the rules. That's my obligation. And my license is also at stake. And so is the license of everybody on my team that's working on that case. And I'm not going to risk their license or my license or the wrath of some judge, particularly for them, so the public can see a document. That's not the way it works. And if there's frustration out there, I understand it. But that's the way the system works.
So just last question, you and the governor then kind of are on the same page on this one.
Absolutely.
You think he handled this correctly, not releasing it
Yes.
prior to this?
I said that this morning when I was talking to Gene. Yes.
Do you think the
That's the
governor
truth.
should not have mentioned that this was being done though
I
to the
can't,
public,
you know.
because that sets up the public expectations that we're gonna get to see this?
Look, how the governor's handled this bridge closing is for him to explain. How he's building the new bridge is for him to explain. I'm a lawyer in this instance, and my job is to represent you as best I can. And the best chance for us to recover money from experts who we allege did not guide the state properly on the repair and construction of this bridge is to try that case, not in the newspaper, admittedly, or on What's Up Rhode Island or whatever the heck it is to try it in the courthouse down the street. And that's what we're gonna do. All right? Oh, there's a healthcare roundtable tonight here in the office. 40 doctors are coming to discuss healthcare. Are we gonna do a preview of our option? Yeah, so there's gonna be a preview. Somebody asked me about our public payer option. When they interviewed me recently, I don't know if that report is in here, but there's gonna be a preview of that, something we intend to roll out in the next legislative session. If you wanna hear our plan, you'll hear it tonight. I can actually remember that one. But I believe that is at what time? 5 o'clock? 6 o'clock, here in the office. All right, it's open to the press. Should be about 40 to 50 doctors. All right, everybody, thank you so much for coming. Appreciate it very much.
Thank you.